Hey everybody, John Kublank here, and we have another amazing episode of Off the Cuff, all things healthcare, and none of this would be even close to possible without my amazing, just extraordinary, super talented co-host, Miss Arlene Maxim. Arlene, how are you?
I'm good, Sean.
Oh, thank you.
I wish I was riding in the car with you, though. It looks like
I know, and you would
sunny
think
day. Yeah.
you think I'm being driven around, but I'm not. I'm actually driving with my knees. So we'll see how this works. No, I'm just joking. I'm just joking. I have my amazing sister-in-law and director of nursing with me driving, Ashley Kublank. But enough about me and Arlene. We are extremely excited to have CEO and extraordinaire Mr. Jeremy Powell. Jeremy, how are you?
Hey, doing great. Thanks, John. Hi, Arlene.
Hi.
And talk to me a little bit about its Acclivity, right? Did I say that right?
It's Acclivity Health Solution.
Yeah. So talk to us a little bit about that. I was doing some research, looking into it. It seems like y'all are pretty cutting edge on what you're trying to do in this space.
Yeah, but it comes on it. That's true, but it comes on the background of about 23 years of our senior team being together. We've had the fortunate circumstance to work at the intersection of data and clinical and financial outcomes for that almost 2.5 decades now. And what we realized in all of that work is there's about 5% of every population or pool of patients that consume about 50% of all of the clinical time and expense. And that doesn't matter whether it's an aged adult or an employee-based pool. And what we were really focused in on is how do we identify those persons that land in that space, because it's not the same 5% every year. It's what's called a rising risk pool. How do you identify that rising risk pool, and then how do you engage them with wraparound and support services that really drive better outcomes for them clinically and financially? And that mission we've been on for a little over 6 years now, and been very excited and successful across about 200 customers so far.
And where are you located, Jeremy?
So we headquarter out of Jacksonville, Florida, my hometown. So our core leadership team is there. Although we do have parts of our team spread across 14 states. We weren't pushed that way by COVID. We were always a virtual company, but headquarters for us is in Jacksonville, Florida.
Oh, okay. You're not too far from me. I'm in Fort Lauderdale, so you're not far.
Yeah, and hopefully this is all we're going to see of hurricanes this season. That would be nice.
I know. I've been watching it.
Yeah.
So what are you having, from my perspective, I've seen a lot of issues with executives or individuals in healthcare really buying into new technology and data. What are some of the kind of issues that you're seeing with people adapting this sort of, new technology into what they're already using?
Yeah, so if you've read the books or seen the Brad Pitt baseball movie Moneyball,
love it.
That's a great pop reference, a pop culture reference to what really has to happen. So just to give people that may not have seen that movie as an example, Major League Baseball relied on an apparatus for scouting players using things like their physique, how they bat, batting stance, how they hold the bat, how they throw or catch, sort of intuition as a means to decide who to field on their teams. Medicine has somewhat done that over the course of its life cycle as well, where we rely on someone's clinical acumen and training and experience to sort of dictate what happens to patients. What's been sort of circling around our ecosystem for a long time is that clinical decision support can really improve outcomes if we can bring more data, even if it's data just into that clinical person's acumen, intuition, and experience. And that data needs to be concise. It needs to provide insight, and it needs to be able to drive to workflows that are naturally occurring. If you don't have those three components, often the persons that are already overwhelmed, there's so much staffing shortages. If you don't make it easy and they can't literally see the aha in the moment, they won't gravitate towards it.
Yeah, I think that last thing that you said, like working into a path that's already a reasonable workflow, it's that I feel like is such a huge part of it and oftentimes overlooked. It's like, man, but this is going to change all of your patients. This is going to change all this stuff. And also you have to learn this whole new process, procedure, software system, all this sort of stuff. And you have to do it overnight to make this all work. And it's like, yeah, that's not going to happen.
Yeah, it never gets operationalized if it changes the synchronicity of how medicine gets practiced. It has to fit into that workflow. So we think about that specifically in sort of three specific domains. So point of care persons can't get distracted by some alert fatigue or notification fatigue. And so we build what we call a banner or an at-a-glance document that literally is consumed as they're working that patient up in their record already. So they don't change what's already been sort of built into their mind map. That's point of care. For persons that are, intake, access, admission, or other clinical personnel or non-clinical operations persons that are centralized, they need to think about, how do I do what next? And so we prioritize their effort. And then the executives need to know, is what we're doing working? Am I seeing financial levers improve? Or am I seeing trends related to quality or other kind of outcomes, satisfaction scores? Am I seeing those improve? And so those are the three things we focus on to make sure we can be operationalized really simply in the current workflows that already exist.
And is there a part of the process, at least either in the onboarding process of your software, your system, or throughout the process, where the end user, the company, is actually, giving feedback about, and I was thinking about it at first was just the call fatigue, or, whenever I was working for a remote patient monitoring company, we would have, what was it? The red notices or whatever. And the nurses
Sure.
would get those fatigues because it was something to raise awareness, but it really needed to kind of be refined from the nurse's point of view. Is there some of that goes on, or is this all kind of happening behind closed doors?
No, it's definitely, it's a life cycle. If you think about like people that use Amazon to shop for any of their consumer goods, Amazon adds features, several hundred of them into their software every day, and we are none the wiser. It just keeps getting better and better. So early customers will definitely have learned with us as we roll it out. But as we've been at this 6 years now, with every new release and iteration, things get simpler, more less cognitive load, less understanding that has to happen. So like if you picked up an iPhone today and you've been an Apple user forever, you know how it works. But if you weren't and you started on iOS 15 or whatever, which is the current release, and you'd never had one before, it would feel foreign. So we do a good job of onboarding persons, training them. There's a lot of turnover in healthcare, so we have to do it iteratively. And we do a good job of getting folks a baseline knowledge. And then with every release and every new feature, we do a good job of sort of showing them how this is making that life easier and it's not causing alert fatigue. One of the ways to do that really well, John and Arlene, is to tie it off to things that are already the incentives inside of healthcare. So, think about an emergency event or a crisis event that happens inside of a post-acute organization today. That often will roll through a number of parts of the organization, and you send the closest nurse without much information to go and inform like that family about what to do. Our system would allow for that to be not just the closest person, but give them information such that they show up not as a cold, sort of first interface to them. The system knew, you guys would know in intake and access and crisis management what's happening, but that nurse often is giving very little, a snippet of what's going on, and they walk in pretty cold to that family. Our system would be able to actually support much more evidence to make that first encounter, though it's not her patient, but she was closest, far more valuable to her and to that family.
What
And
type
that's
of providers?
You go ahead, Arlene.
What type of providers are you currently working with, Jeremy?
So today we work with traditional primary care, geriatric practices. We work within skilled and long-term stay facilities with organizations and practitioners that are in those facilities. We work in what we define as, I think the market also defines post-acute, so hospice, palliative, home health organizations. And then we work in risk-bearing entities. Those could be health plans or ACOs.
Okay.
In an ideal world for us, when you have all of those different parts
Sure.
that are often fragmented in the normal ecosystem, when you connect them all together on our platform, everybody wins. So you're giving more evidence to support persons at the point of care. You're giving more evidence inside of the navigator or non-clinical operations team to really do a better job of sort of supporting all the transitions that will have to occur. So if a patient moves from home health to a potential skilled journey, and then back to home health, and then to palliative and hospice. Like all of those things can be made seamless because we know the patient from the first time they were touched. And if we have a payer relationship or an ACO relationship, we know that patient's data across every individual kind of encounter, every procedure, every medicine, everything that can be done about that patient's known. And then we distill it down to what you might need to know to do your job better as a nurse or a physician, as an intake person in a non-clinical ops role, or even honestly at the director level for making decisions about workforce management.
In the post-acute world, then in home care hospice, are you integrated now with any EMRs?
We do. We have about 40 different electronic health records that, again, when I mentioned to John, we can't break the practice of their daily routines by having them log into some other thing or do a different workflow.
Right.
So we directly integrate into about 40 different post-acute EHRs today. It's a little easier, full transparency. It's a little easier in the ambulatory and the acute space because ONC required them to get certified for interoperability.
Sure.
But we've been doing this for 6 years in that space. So we've connected, if you're on an EMR, we've either already connected to it without those interoperability capabilities on our own, or we're in the midst of deploying our fabric to interoperate there as well. And so we started that endeavor in, full transparency 6 years ago. Our very first customer was an ACO. Our second customer was the largest practice within that ACO. Our third customer was the largest palliative home health and hospice in the market in that same region, and put it all together. And so that's our history. And our biggest segment is the home health, hospice, and palliative care segment.
Interesting. That was something
So
you were
on
interested in. Yeah.
I'm sorry?
John, I think that was something he was really interested in, as a hospice and palliative space.
Yeah. Maybe something that sort of ties it together for everybody that's on the podcast. The ONC created interoperability, and certified the platforms away from us in 2015. But Medicare is not requiring that certificate for our platforms yet. But with Medicare's, requirement for in 2021, they suggested that by 2030, all of traditional Medicare will be under some version of alternative payment, call it ACO, accountable care, or call it value-based care. And what that really means is they're going to start reimbursing these patient journeys, not just because of take hospice where they have levels of need defined by routine or continuous or general inpatient, but by how much this patient's needs documented in Medicare's world, which is all of these patients' journeys, which will define for them how sick they are, how much frailty they have, et cetera. And so in our system, and why we're focused here in this post-acute space, there is so much opportunity for organizations to be ready for this big shift that Medicare is putting a lot of carrots on the table. So our customers, as an example, have taken risk on patients already. Going back to 2021 with the direct contracting entities for high needs populations, and they're now called ACO REACH. We have 11 of the 14 ACO REACH for high needs using our system today. And a good example of that is one of them in our state, Arlene, in Florida, for 626 patients in that first year in 2021. Their check from Medicare was $3.5 million in the savings they were able to generate using our system and their approach to care for those types of patients that are high needs, that meet exactly the hospice, the palliative, and prior to that, the home health kind of categories.
That's amazing.
That is amazing. And I'm in a lot of my experience in the post-acute world, I find that the part of the reason why we're not transitioning very well is that our incentives have not really aligned very well. It's hard to transition from a home health to a hospice if the home health organization is incentivizing the home health to keep their patients on service. It's hard to transition from, one level of care to the next if we're not incentivizing the right way. So I think value-based care is really where we have to go in ACOs as a kind of looking at the larger picture. But I think your product now provides really good, solid data that it's hard to, just go off of our anecdotal data anymore. But that's what I feel like I'm seeing is people are not wanting to transition, not because the patient isn't qualified for transition, but because it's hurting some sort of their metric. But now hopefully we have more oversight on that. You know what I mean?
Yeah, I think part of what we're really talking about is something I call the two canoe problem. It's hard to have one foot in one canoe and one foot in another. And whether that's a service line like home health to hospice, or whether it's a payment model like fee for service to value-based care, those things create what's really tough for humans. And our human nature doesn't like limbo. We don't like not knowing and not having control.
Yeah.
And so if I'm a home health leader, I know what my metrics are. I've got to hit them. And often a transition to hospice hurts my metrics. So what these programs, especially what Medicare is trying to do with some of its reimbursement incentives, is to sort of say, let's give you the patient for the full 2 years, and you can define the model of care that best keeps them from other incentives that occur, like an oncologist that wants to do chemotherapy till the end of life, or a hospital that wants to do acute, skilled, acute, skilled, acute, skilled to the end of life. The patients would much rather have trust and rapport built with an organization like a home health, hospice, and palliative organization, where they can be asked, well, what do you want as a person? Not what does your cancer diagnosis say we should do? And that's what Medicare is incentivizing. That's why, again, 626 patients can net a $3.5 million check from Medicare for just an 8 months of service. Like, that is real adult money to change the behaviors of organizations who have been stood up in this first canoe, which is fee for service. And now they're going to really incentivize through carrots, model of care improvement to align to patient need.
And how are you seeing this react with the readmissions? I know that that's really been the hot topic over the last 10, 20 years. Readmitting to the hospital is our one of our largest expenses, especially in our senior population. Have y'all seen a big impact with organizations utilizing your service in readmissions?
So we make a couple of predictions that are, driven by analytics. The first of which is, what's the likelihood of a person having their initial inpatient encounter? And then another prediction is, what's the readmission or rehospitalization likelihood? Those are percentages. So out of 100. And then we make another one, which is, how likely is this person to be in the top 5% of, again, that rising risk, the top 5% of spend for the next 12 months. So imagine an organization that's a hospital that gets penalized for readmissions. Imagine they also have built an accountable care organization themselves. They have a couple of incentives now at play here. I don't want the readmission penalty, which is a stick. And I know that if I wrap around home health, a hospice, or palliative for the right level of patients, I can sidestep those other two bad things. My ACO losing money because I'm not doing the right level of care and it's too expensive. And I've missed this prediction of getting a rising risk patient the right level of support. So our system, when we, again, anchor around these things that already exist, like readmission penalties, like ACO incentives, and like recognizing how hospice can be delivered for patients that are in the last 12, I'm using 12 months as an example. The last 12 months of life, you have to start have conversations. Otherwise, you're going to get 6 days versus 6 months of benefit. So we predict 12 months, we predict 6 months, and we predict 3 months, and we predict 10 days. If you think about how you build your models of care, you could do home health and palliative in those 12-month predictions of death. You could do hospice right at 6 months. You could do service intensity add-ons in the last few days of life. So our system's purposely built to help you do better at the way that is currently designed and get you ready for taking on more risk when you have the opportunity in your market.
Yeah, and I think you said it with the service intensity add-on, that really, depending on how large your agency is, could really be a struggle to make it worth it from an operational perspective, because if you're missing visits, if you're not catching it the right way, you're including a lot of labor that you're not going to get reimbursed or see that increase in reimbursement. And what I've seen, a lot of smaller agencies, especially, just don't want to waste time on it because it's more of a headache than any sort of reward would ever be, even though it really is beneficial to the patients more than anything to actually do that service intensity add-on at the very end.
Yeah, we agree. I think it's in that the canoe that's fee for service that's the most the well-traveled path for all of us today. Service intensity add-ons one part of it, but also if you have contracted beds inside of some inpatient facilities, we actually flag patients across about 40 states so far, that if I had a hospice patient live at home being served under general care and we've trained him to call us first, but it's Thanksgiving and the son comes into town and creates havoc and calls 911. We actually know that right away, like literally in real time. So parts of what we help our organizations do is to navigate that patient to a contracted bed. So we don't have even the penalty for the hospice when it comes to how they're going to get reimbursed for that bed. If that patient revoked or didn't and got an intensive levels of care in the wrong bed, that's an expensive accident as well. And so in that canoe that's fee for service, we have service intensity add-on, we have placement, we have event notifications for emergency department registration or inpatient registration. So again, you're going to use your staff far more efficiently if these things are real time and known, versus how you often find out, like there's a phone call that happens a few days later and you miss the whole window of being able to sort of navigate that triage and then get that person placed in the right location.
Well, there was a report, I don't know if you noticed it, but the Office of Inspector General's put out a report on the 5th of this month, and they indicated that there were over 50% of home care companies that were not notifying the Medicare program of a significant fall that caused injuries in the home. Some of that had to do with the home care agencies, I would suspect, not getting the information. So having something like this where they would actually get it in real time would be really helpful in decreasing the percentages of those home care agencies that didn't even have the information to work with to notify.
Yeah, and it's really seamless in most markets to, in essence, know anytime a journey is, an admission for a journey or a referral for a journey occurs in the EMR, because we're connected to the EMR, that becomes a whitelist patient for us. We put them on the whitelist, in the state or the region or the nation, depending upon how we've contracted. If that person presents and gets registered in any facility, we know within a second or two of that admission, that registration. And so imagine the home health not only being able to sort of submit to CMS this has happened, but also be able to recertify for a longer journey where PT now is involved, where a patient might have been getting skilled care for for other reasons.
That's right. That's a really good point.
Yeah, and that's the stuff that again, I think creativity gets defined as sort of taking things that are currently in their native form and have been for a while and putting them together in different ways, right? Yes. Think of puzzle pieces that you find that actually fit in another way than the way you've known them for a decade or so. Event notification services have been out there for a long time, but hospice, palliative, and home health haven't used them the way that other parts of healthcare have. Risk, like ACO risk, has been out there for over a decade now, and you're now just first getting your toe into that sort of part of the journey. Medicare has told us time and time again through their behaviors that they'll use carrots a lot in the beginning, and then eventually it becomes a stick. And if you're not in by a date, let's call it 2032, 2033, at the farthest we could look out and sort of say you can drag your feet for a little while longer, it's going to be penalties. You're going to pay a tax. You're going to pay a penalty, and the penalty will come as reimbursement shifts, but it'll also literally come as penalties. So we live through this in the primary care side where, in California, as an example, no one takes traditional fee-for-service Medicare anymore because there's more money in managed care for those clinicians that are working there. That's going to be the landscape across the United States for hospice and palliative specifically in the next decade. Mm-hmm. So getting there where you get this payment from Medicare to subsidize the growth of your model of care, of subsidizing, how you, rebuild what your care delivery, and transform what your delivery of care is. Let them pay for that. Let them subsidize those costs. And then if the folks that are, going to be the most successful are the ones that, like the group in Florida that had 626 patients just getting started. Now they're, probably over 1,200. So they doubled in that short amount of time. They'll double the dollars available for them from Medicare. And they're still only managing about 1,200 patients per year in that environment. So it doesn't have to be big. Everyone can play in this game.
Wow.
And I know you might have said something earlier, but one of the issues or variables that I always like to look at when we're talking about cutting costs in healthcare is social determinants of need. Are you looking, or is there anywhere in your algorithm or when you are talking that you're able to sort of evaluate or comprehend or assess people's social needs as a part of their overall healthcare needs?
Yeah, we have all of the geo data directly from, inside of our system, directly from multiple sources that allow for us to know by 7 and 11 digit zip codes what is prevalent in that market. So they always say, you want to know how you're going to turn out in life, give me your zip code and I can get you really accurate. So that exists in our system. And then there are codes that people actually are starting to code all throughout healthcare. They usually call them SDOH wheels. So there's a wheel inside of Epic. If you're familiar with Epic EMR, there's a wheel inside of Epic as an example, and it documents safety, access to food, shelter, stress, etc. And so when we have that about individual patients in our system, we pull that forward. When we don't have that, because it's new and it's starting to be built at scale, but when we don't have it about a patient, we present the geo level data. So again, down to that 11, digit level zip code for 10 digit level zip code for us to actually know what's likely going to be by percentages. And it'll actually show you in our system how prevalent is issues related to food access or access to care or access to, safe living or how much stress is in this market. And you can tell that by, levels of poverty, levels of disease, again, access to care. All of those things are predicted, but where there's actual codes about Arlene, the patient, those are pulled forward. Our system also captures wheel level detail. And again, it's just where you're looking at this person across those very different social determinants and assessing, does this individual person show a marker that you need to document? Because again, you're going to get paid by that documented marker over time, because they'll require more effort than a person that doesn't have a marker like safety or stress.
Interesting. Do you have any papers that you've written or that you publish? Not necessarily you, but your company publishes that our listeners could take a look at?
Yeah, I think I'd start with where we were the most interested in the very, very beginning of our work. We started looking at how well do humans predict the 6-month, mortality requirement of hospice as an example. And the best of the best humans get it right about 12% of the time. So if you were to ask, if the person's being served in some upstream service like home health or palliative, tell me which of these patients die in the next 6 months, you'd get 12% of them right. Our machine learning model, which is another word for artificial intelligence, when we first documented it, was we co-released this information with Oliver Wyman, which is a large healthcare consultancy company. We did that in the summer of 2018, and we were able to predict 4 times greater than humans. So about 48% of our predictions were accurate. And the way you measure accuracy is the people that we said were going to die did die. That's a true positive. And then how many deaths occurred in that 6 months in total. So you're not going to get all of them. There's going to be the trauma and accident kind of things that happen. There's going to be a widowmaker or some other bleed out that occurs that you couldn't predict. But today that's better than 90% on the true positives and better than 50% on recall, which is how many of all the people that died, how many did you get? And so imagine if you could find a medical director for your hospice that when they said a person would die in 6 months, 9 out of 10 of them did. Like you'd hire that person immediately. So that's our system today. And that's a white paper that's been published. And I'm happy to sort of point to a link. If you do a Google search on Oliver Wyman or Oliver Wyman Acclivity Health, it'll be the top result. It's a podcast as well. So if you people like podcasts, this is another podcast. Nice. But it's also got all the documented paper details in that release itself.
Interesting. Do you have any conferences that you're going to be attending soon?
I'm actually at NACOS, the National Association for ACOs today. We're also going to the NHPCO conference, LAC. We're speaking at that conference about value-based care. Robin Stavash and I will be speaking on behalf of that concern and challenge for hospices are going to have to face alternative payments. We're also at the American Academy of Home Care Medicine, so AAHCM. Those are all October conferences for us, and so you'll see us out and about if you're at any of those.
Okay, great. That's perfect.
Yeah, it sounds like y'all are busy and y'all are just continuing to grow. But I'm curious, where do you see yourself or this company going to next? I mean, you're already trying to accomplish a lot. You're bringing in a lot of data like that we wouldn't have seen in hospice, or you're trying to connect these areas, but we kind of have these donut holes in healthcare. But
Right.
where do you see the company in the next 10 years going? Or is this still going to be your focus for the next 10 years?
So I often think like one for all for one, and the hospice benefit and the persons providing hospice services today are going to face really big challenges, and so what we're trying to do now for this particular market is to build some bite-sized solutions for the smaller players that are going to largely struggle because they don't have the scale, the capital, and the experience of sort of making these changes at the pace they're going to come. And so our previous approach was to go face some of the bigger nonprofits and profits, but nonprofits were where we really sort of got our foot in the door and stayed loyal to. When they were big enough under a certificate of need, they would have capital, resources, they would have the interest, they would sort of be working on this problem. We could sell the enterprise solution, which would allow them to sort of nip and tuck as we went along in a project. Smaller organizations need for us to have them consume it in bite-sized pieces. And so for the foreseeable future, it's really trying to get all of us to start working towards being ready for this, because if not, there will be a lot of service failures. There will be parts of rural America that don't have coverage anymore because for-profits will not go to places where patient need exists, but there's not enough saturation for it to be profitable. And so I'm trying as a mission myself to do this in a way that keeps all of us marching towards this really good outcome and not leave any part of the system behind. And so that's the foreseeable near term. Long term, if you do that well, and we can pull all of us in the same direction towards the same horizon, you could take all of that to risk, and everybody would have the ability to capture these carrots while they're out here. And I think we have about a decade of carrots before it becomes sticks.
Yeah, and I mean, I say this all the time. I think, we talk about our government spending in Medicare, right, being funded by our payer, our taxes. We all would win if we could spend our money wiser, right? If we're not having these errors in medicine, it's the errors that are costing us money that we would otherwise not have to spend. And if we could just get a grasp on that, we would have a much more robust healthcare system, I believe.
Yeah, on that topic, I'll tell you, our origin story includes, palliative medicine as the model of care to support this transition to patient-centered whole person care. I wish that the first thing that we did as a business, if I could go back, the one thing I would change would be to go back and say, that's the right model of care. It's the wrong reimbursement today. And let's focus on what happened to us in 2021 was the first high needs ACOs came out. In essence, that was the first time that the dollars were tied to the right level of care and the right kind of care. What I would say is going to happen is that's all going to accelerate. We're literally going to see, in essence, what palliative and supportive medicine is be the thing that gets the most attention from a reimbursement model perspective moving forward. The game you have to play to win at it is attribution, which is, how do I get claims aligned patient attribution for my palliative patients? And that takes us talking to you about, well, what does an attribution model look like from CMS? How do you get attribution? What services can you be billing for that are augmenting your palliative approach, but really you're willing for them to get the attribution under these models? Because that will be how you win the day when it comes to revenue. And I know it feels backwards to most people that are building their models of care, but palliative is the right medicine. The model of care that's going to win the day, though, is one that reimburses greater than your cost. And palliative isn't that yet. And so marrying those two things together is what Medicare is doing for us. And we can literally rise to that challenge as a group and take all of these patients to risk. And the dollars are here. 50% of every bit of the spend every year in Medicare is in this population, and we can serve it.
So another thing that's interesting about your data too, right? So we understand from a high level that if we're taking care of our patients better, they should be happy, right? Mm-hmm. So especially in home health and hospice, quality of care should equate to quality of service, and what our star rating should predict. So have
Yep.
you looked at, or have y'all talked about even a regressive model to look back at what you have and compare it to star ratings to see if there's any sort of correlation in that?
Yeah. So think about today, what we've built so far has about 10 terabytes of data on about 10 million patients. And so imagine, and again, this is usually daily at the sort of slowest frequency that we're getting data. That's sort of some of that real-time clinical. But the claims data is always somewhere between a week to 2 weeks to a month. So imagine you could have quality like you're talking about, satisfaction and star scores like you're talking about, but also imagine what you can show as your cost reduction, right? Which is where the money is in tomorrow, right? Tomorrow's money in medicine is going to be you get a budget, and how much ever you come under that budget's what you make. Imagine having 6 years of that much data to showcase what works and what doesn't when it comes to quality and cost and utilization. Like that's the holy grail of what we've got in our hands right now.
Yeah, I think that's at the end of the day, when you're able, like you said, tie everything together, it's going to be a much more powerful, robust solution than what we've seen.
Yeah, and the fun part is like reimbursement models are going to shift and they're going to be visible to us. So you can pick where you want to play. So some people are lucky enough to be playing in the guide, which is the dementia related model. Some people are going to be lucky enough to play in the making care primary model, which is really just advanced illness primary care in 8 states. Some people are playing in the high needs reach ACO space. Some people took MSSP risk and are making that high needs. Like there is a lot happening right now, and that's all Medicare. That didn't include anything that's happening in VBID. That didn't include anything that folks are doing on their own with palliative medicine reimbursement in the Med Advantage space. So if you're not talking about these things around your senior leadership table today, like that's a missed opportunity because it's real dollars that are at play in this carrot season that we keep talking about.
Well, and you don't want to be behind, because it's very often that a lot of these, programs, when you're starting to hear about it all the time, it's slowly about to be done. It's ending.
Yeah. I always say, how does a person go bankrupt or get divorced? It's a little bit at a time and then all of a sudden, right?
That's
and
it.
so
Yeah.
if you're not cautious about the early trade wins, by the time you're hearing it on every media source, you miss the window. You've literally missed it, and it'll just be sticks at that point. And oh, by the way, when they start doing penalties, some of it'll come from the networks that you weren't a part of. Like you weren't in the network where you could get the good reimbursement, and now the penalties could be you only get the patients that are catastrophic, and you're extubating with a day or an hour of life left. Like that's not hospice, but that's what's left, and you don't want the island of misfit toys to be the only patients you get to serve.
Yeah. Well, yeah, there's a lot of reasons, especially, I mean, we don't even have time to get into it, but your labor, try to find a staff that's going to stick around for those patients day in and day out if you're not paying them 20% more than they would get at another hospice. I mean, it just turns your model 100% on its head.
And imagine when networks get formed and your network performance and your adequacy is tied to how many patients that you actually have satisfaction scores from, and you're only left with rural America, and you can get to 3 people a day.
Right.
So I can be there in a day and a half. Like, okay, but it's crisis now, right? So you can't even serve the patient.
Yes.
So it's just the other end. One end is intensity of care, and the other end is just no saturation for patients. So you can't get to them.
Right.
And I think that's the scary part, is those penalties don't have to be financial. They literally can just be you're carved out of playing on a field where you can win.
And the market is changing. This is why we want to do a podcast like this, because this landscape is extremely, volatile all the time, and is changing, and there's new regulations, but there's also these new technologies that come up that, hey, if we have all these changes, we might as well try to make it as easy for ourselves to make these actionable decisions, which is, I think, a lot of what you and your company have worked towards, is not just giving you data, but giving you something to do with that information. And that's really where the secret sauce, I think, comes in, is give me some direction. Help me move to that next step, right?
Yeah, we always talk about 3 pillars. So the first pillar is data and analytics. The second pillar is what do I do? Our insights. And then the third pillow is, how do I report, thinking to you mentioned, how do I report my successes or where I have to improve? Like, so it's sort of looking back in history and review mirroring, like did what we did work? And that's literally that's our company. And so what's exciting about that part of working with you all is often that's not the approach that's been, there's been no luxury or no dollars afforded for doing that work in your part of healthcare. Right. Unfortunately, you're going to have to take crash courses with us on, well, this is what it takes to be successful in the models. Once you get it started, it's really just following what's natural. But it is switching from this idea, like I use Moneyball, switching from this idea of I've used my intuition forever.
A gut.
And I've been in hospice for 40 years. The benefits not changing. We've had one plan. That's all going to go away. Right. To, okay, now I'm going to be measured on things like days at home and hospital rate per 1,000. Like, how many times did my patients hit the hospital per 1,000 patients? And that's not a measure that anyone's ever measured at any CAP score or hospice compare. No, it's just not. Right. And those are the measures of what matters in the future. So you got to start building your own data set with us, and then building towards, how do I provide insights to run the right plays on the field, and then scoreboard how you're doing. Like, how did we win this quarter? Did we win this month?
Yeah, and I worry about home health more than hospice, because margins and revenue are already so thin. Trying to add additional services on, it sounds like y'all are, like you said, trying to get those bite-sized pieces so they can just start adding on. But it's becoming a very difficult market to stay a part of, with all the changes in the razor thin margins on some of these home health companies. Luckily, hospice being different. But my challenge is always trying to get that home health owner to be like, look, you're going to have to spend the $500 a month, $1,000 a month, or whatever, because you're going to want to save it. And they're like, I don't even have that money, So it's a challenge. It's a challenge.
Yeah, we see the same challenge. The way I think that people will think about it in the not too distant future is home health, hospice, and palliative will not necessarily be separate service lines. There'll be staff that works on very specific kinds of patients, but your reimbursement will be tied to the total spend, not to the specific journey.
Got it. Oh yeah, that would make a lot more sense. I would be on board with that for sure. Arlene, do you have any other thoughts or questions for Mr.?
I don't. I just think that this is like really, really important information that people really need to be paying attention to.
If anybody wants to get more information, what is the best way to reach out? Going to your website, probably?
Yeah, there's a way to request a demo out there. But then always you can reach sales@acclivityhealth.com, and that'll get to folks that can help you. But you can request a demo, that'll get to folks that'll help you. And we're at acclivityhealth.com, ACCLIVITY health.com.
Acclivity Health. Awesome. Well, Jeremy, thank you so much for coming on our show. We really appreciate it. Sounds like you are doing big things, and we want to stay connected so we can hear more about it as you continue to grow and redefine this industry and this landscape. So thank you so much.
I appreciate the opportunity. Take care, Arlene. Thanks, John.
Thank you. Thank you, everybody. I appreciate y'all watching another episode of Off the Cuff, All Things Healthcare. Thank you, Miss Arlene Maxim. Your presence is always amazing. And Jeremy, thank you again for coming on the show. Until next time, guys. Thanks.
Thank you.
Bye-bye.